interesting session. So I will start the session and I will ask our first presenter, Dr. M.S. Kanwar. He is a senior consultant, respiratory and critical care sleep medicine in Indraprastha Apollo Hospital, Delhi. He is a founder of Apollo Sleep Disorder Institute with us and he is a lead in lung transplant. I welcome him.
Thank you, Nikhil. And thank you, Dr. Ranjan, for inviting me for this presentation. Interesting as it is, we have been talking since 1995 when we started sleep medicine. Dr. Suri was busy in Safdarjung Hospital doing it, and I started in 1995 in Apollo Hospital. And Dr. Manveer Bhatia sitting here soon after she started. So we were the pioneers who started just talking about this disease and spreading the messages, what it is and how it can cause various cardiovascular, cerebrovascular complications, and so many others. So we'll talk a little bit about the pathophysiology and how we evaluate quickly, So whatever time I have, so we'll go quickly into that. Now this is, do you have this pointer, please? Pointer. Give me a pointer. So this is normal structure. If you do an MRI and lateral view, you probably would see something like that. But probably what you're seeing here is a rather too big, bulky tongue. Normally it's not that bulky, except if you have metroglossia. But anyway, this is easy to explain. Okay. So you can see the flow of air is been marked through the nose and also through the mouth. But the problem occurs in this region, where there is a collapsibility. And when you have a collapsibility there, then there is an intermittent apneas, hypopneas, partial obstruction, complete obstruction, leading to oxygen going up and down. So this is how, we encounter problems in this situation. And anatomical narrowing, well, you may have macroglossia, you may have micrognathia, you may have retrognathia, you may have a tonsil bed which is very heavy, you may have an overhanging soft palate. Some people have very large bulky uvula. So end result is if you have a narrow side-to-side or opening in the oropharynx, you just look at it and you know you're dealing with an apnea. You don't always have to go for a stop and score to see whether the patient really fits in with a criteria where you should be doing a sleep study. So you probably will get a fairly good answer just looking at it and asking a few relevant questions. So, of course, obese people have more fat deposition here. That's why if you have a high BMI, the chance of you having OSA is much higher. Now, if you have two patients, two people looking similar, the oral structure or facial structures look similar, yet if you do the sleep study, one of them may be showing severe sleep apnea, another may be showing a mild sleep apnea. What is the reason for that? That is because the dilator muscle tone could be very variable, and how the arc to cause the dilatation of the muscle works in that patient would determine whether it will allow the pharyngeal collapse or not. Now, if that is the case, then obviously it's a lot of physiological, it's not just anatomical, there's a lot of physiological involvement in that. So then loop gain, of course, if you have hyperventilation happening after obstruction, the carbon dioxide keeps going up and down. We don't usually measure that. We don't do a capnogram in these cases. It's well established. So, and the variations are mild, so it doesn't really bother us clinically. In pathological sleep state, as I said, pharyngeal collapse. Pharyngeal collapse can be complete, can be partial. And when the airways are closed, the patient is, it's like that, making an effort, creating a negative pressure. So the pressure in the thorax keeps increasing, becoming more and more negative. But that more negative the pressure, the more closure up there. But then the brain arousal happens, which leads to sudden, gush of air going in because the muscle tone comes back. The story is of muscle tone just coming back and then arousal is happening. It could be micro-arousals, and this goes on throughout the night. So, ventilatory instability is there, pharyngeal dilator dysfunction, as I said, obesity, fat deposition, reduced dilator tone, and upper airway narrowing. Well, again, same thing primarily. Obesity, increased neck circumference. Craniofacial abnormality. Some people say, I have a family member, my father, my uncle, who is also having sleep apnea, and we are not excessively obese. Yet we have sleep apnea in 1, 2, 3 family members. Man, if you have a facial structure which helps you recognize this guy seems to be from the family. He seems to be Jonas. You look like similar. Same way, guys, we have internal structures also actually a bit similar. So, if somebody has in the family, in first degree relatives, a preponderance for narrowing the upper airways, so one is now the other is thick tongue or tonsil bed or the soft palate or the large uvula or a crowded side-to-side opening of the oropharynx, you actually may have more family members having the same kind of problem. So it's not a surprise that you have OSA in many families. I treat dozens of such families with multiple members having the same problem. So I'll explain the negative pressure thing. So obesity, tissue hypertrophy, nasal obstruction. Is it a major thing? Some people say, no, nose is obstructed, so we will do some surgery here and the problem will go away. Well, think of it. If you have nasal blockage, why won't you breathe through your lungs? You would. So I think it causes only a very marginal rise in OSA. It is not the cause of OSA unless the patient cannot open the mouth. If the patient cannot open the mouth, how can he eat? How can he even breathe properly? So it's all hypothetical. I feel if the patient is having a nasal obstruction, it aggravates sleep apnea a bit, but beyond that, no. Age-related, yes. Older the individual, the sleep apnea tends to increase, mainly because the muscle tone goes down. But beyond a particular age, like 65, 70 years of age, the muscle mass, the fat tissue actually starts to go down. So that is when sleep apnea can automatically start to come down, can reduce. So, changes in blood gases. Now, saturation is what we measure during our sleep study, or even by routine oximetry, if the patient is sleeping. Now, you will see crescendo, decrescendo, going on the entire line. In a normal individual, why should the saturation even change in the first place? But in apneics, sleep apneics, it can go down sometimes in 60s, 40s, 30s. I've seen levels in 20s, and our technician gets scared, wakes the patient up. But he doesn't want something happening in the lab itself. We have once lost one patient in the last 30 years that we have been doing sleep medicine in India. I've been doing since 1995. We lost one patient. It was one of my colleagues. During sleep, he had to die during apnea in the lab. It's just a chance. So, sleep fragmentation, because every time the apnea will be broken, there will be an arousal. So that arousal is going to lead to sleep fragmentation, systemic inflammation. Systemic inflammation is what is going to lead to, and also there is sympathetic overactivity. These are the things which are going to lead to ultimately hypercholesteremia and the glucose intolerance. So that is pancreatic beta cell dysfunction is there, and abnormal insulin secretion. That's why the risk of diabetes is so much higher in these cases. So we have basically talked about that. So to move forward. So increased AHI. What is AHI? Apnea hypopnea index is number of apneas plus hypopneas, means complete and partial obstructions per hour on an average. So if it is up to 15, the disease is mild, 15 to 30 disease is moderate, more than 30 disease is severe. But besides this number, there is also an element where you should be looking at how bad is the saturation, how bad is the arousals. If the arousals are terribly high, then the quality of life is terribly bad. And oxygen fall is one big aspect. The other big aspect is how much is the sleep fragmentation. Systemic inflammation, which I mentioned, is almost directly related with sleep fragmentation. So sympathetic activity going up and down, and the oxidative stress, which is leading to inflammation, also leads to endothelial dysfunction through atherosclerosis, and that is what can lead to cardiovascular and cerebrovascular events by atherosclerosis mainly, and of course it can cause hypertension. So hypertension in sleep apnea is not at all uncommon, just like diabetes is not at all uncommon. And heart failure, if you're already having heart failure, who wants to die? Stroke. So anything to do with cardiovascular, cerebrovascular, there is a compromise. Okay, I'll skip that. Alright, so coronary artery disease gets worsened. I don't know whether I would say it can induce coronary artery disease, but why not? If it is causing atherosclerosis, we have proven that it causes atherosclerosis, it can induce coronary artery disease also. But certain cardiac death, I've already given you an example of patient dying during sleep study, apparently healthy patient, during a long apnea, very low oxygen. Thereafter, we gave the instruction to the technicians that if the saturation is going below 50, put the patient on CPAP. Just wake him up a little, he'll take a few deep breaths, oxygen will come up, and put the patient on CPAP. So there are neurocognitive effects. Reduced concentration, memory is very important. Irritability, mood disorders, daytime sleepiness. Daytime sleepiness is so common, irritable. The family, the wife will tell you all these mood changes the patient has experienced over the period.
Yes, through the time.
I'm almost done. This stop bang, which is the clinical. This is a N3 sleep, which is actually tissue repair and also to improve our immune system that we have. And this is a REM sleep. This is the rapid eye movement here in the EOG, which is for memory consolidation. And this is the standards N2, which is most common. This is our first page where we just have a look and we know what we're dealing with in PSG level 1. So these are the typical apneas. Straight line means no breathing, and it goes along with the oxygen fold at the same time. So that is what I have to say. And thank you, Dr. Ranjan, again, for calling me over. Thanks. If you have any questions, can I take it now? Because I have to leave for my OPD, my patient OPD.
Any questions from anyone?
Role of mod alert in OSA patients?
Yeah, okay. Mod alert we don't like to give in sleep apneas, but if the patient still requires mod alert-like thing, means still daytime sleepiness, then you have to find the reason. Have you picked the sleep apnea properly? Or have you missed something? Have you missed narcolepsy? Many patients have both sleep apnea as well as narcolepsy. You have treated sleep apnea, patient is in sleep apnea, and he comes and tells you, I'm better, but I'm still having morning wakeful issues. And I can still, watching TV, doze off. In public, I can doze off. If that is the storyline, two things. Rule out narcolepsy. Take the history. Cataplexy, and sleep paralysis. What kind of those things patient can give you? If not, do a study which is specifically for REM sleep. Okay, that is done in the day. So we do MSLT in those days. Other thing that can cause similar situation. There is no narcolepsy, and you don't think it is idiopathic hypersomnia, and the patient is not too groggy. Then it's still groggy. Then look what happens after sleep. Is the patient still having arousals? Because I mentioned earlier that arousals and micro-arousals would determine your daytime symptoms. If your micro-arousals are still there, some people have a very low arousal threshold. Believe me, so low. That is the character of patients who would have a little difficulty in accepting CPAP in the first place, and then having all the symptoms disappear. So these things have to be, and if you still don't manage that, these things are going on, then sometimes we give, in such a situation, last situation, we give something like zolpidem to help him sleep through, rather than go for moderate in the morning. But yeah, in occasional case, yes, we can.
Thank you, sir.
Any more questions? So I think the sleep studies that we do, there is also a component of central apnea sometimes which we see. So they also contribute, but most of the time what we see that if we apply the machines properly, that is also covered. But if we see more of central apnea, then neurological workup becomes more important.
Cardiovascular. Also cardiovascular, heart failures. Yeah.
Thank you, sir. Thank you
Thanks.
for enlightening us.
Thanks.